Well, good morning to all of you. It's evening here in Western Washington. I want to say I've enjoyed this very much. And I'm fascinated by the presentation by Dr. Ramani and also Dr. Narvi. I think high frequency nasal ventilation is an intriguing subject, and I'm also a big proponent of delayed, and now maybe I'm an advocate also of physiologic-based cord clamping. My presentation is about the scientific background and consensus on the 8th edition of NRP, our most recent edition, as a result of the 2020 scientific consensus. I want to thank Dr. Amani and Dr. Narvi, and I'll be the third now today to share with you a picture of my black lab. His name is Scooby. And if he were here with me, he would say hello to you. He does speak. So the 8th edition of Neonatal Resuscitation is a result of the 2020 American Heart Association guidelines for CPR and emergency cardiac care. And here's the reference from Circulation, which is the publication of the American Heart Association, and the citation that includes the new guidelines and the basis for neonatal resuscitation. These guidelines were developed for adult, pediatric, and neonatal populations. And what happens is the guidelines are reviewed, updated, and published by the American Heart Association, and in concert with the International Liaison Committee on Resuscitation, also known as ILCOR. And in 2015, they went to the 5-year updates, and they transitioned to an online format that now uses a continuous evidence evaluation rather than the 5-year periodic reviews. So having said that, we all are aware that about 1% or approximately 1% of newly born infants in the United States will need intensive resuscitative measures to help them restore good cardiorespiratory function. Each section in this summary describes the scope of each guideline, along with the list of most significant and impactful or new or updated recommendations for that portion. Each section also includes a list of critical knowledge gaps that highlights important research questions. And one of those we could say would be how we manage the umbilical cord. So that evidence review that the American Heart Association does, they do that in collaboration with the International Liaison Committee on Resuscitation. That partnership sees that each of these organizations contributes to task forces as well as member councils. In the past, the one type of scientific review was just what they called a systematic review. Now, with the 2020 consensus recommendations, the American Heart Association and ILCOR use 3 types of evidence review. The first is scoping review, and it's an acronym for the review format. We won't go into detail during this presentation, but it allows for a broader inclusion criteria. And then they do evidence updates, and that's used for questions that are not undergoing scoping or systematic review. And then finally, the systematic review takes a look at narrow questions, and they use the GRADE assessment, as I mentioned there. So let's just talk about neonatal life support. I want to share with you the top 10 take-home messages that were shared in this 2020 scientific review. Newborn resuscitation requires anticipation and preparation by those of us, the neonatal or pediatric providers, who train as individuals, or we train with others as teams. Most newly born infants do not require immediate cord clamping or resuscitation, and can be evaluated and monitored during skin-to-skin contact with their mothers after birth. That's been a real change I've seen in practice. Most newborn babies don't come to the pediatricians. If we're at the delivery, they go right up on the mother's abdomen, and they're evaluated there by the team in attendance. Third, inflation and ventilation of the lungs are the priority after birth, and that is not a change. That will remain for the foreseeable future, our most important task is to generate inflation and ventilation of the lungs. The rising heart rate continues to be the most important indicator of effective ventilation and response to our resuscitation efforts. And then pulse oximetry is used to guide oxygen therapy and to meet our oxygen saturation goals. The remainder of the top take-home messages: chest compressions are provided if there's a poor heart rate response to ventilation after appropriate ventilation corrective steps, which preferably also includes an adjunctive airway like an endotracheal tube. The heart rate response to chest compressions and medications is recommended that it be monitored with electrocardiographically, i.e. with the cardiac monitor, whereby we place leads on the baby's chest and we can see an electrographic feedback about the baby's heart rate. If the response to chest compressions is poor, it may be reasonable to provide epinephrine, preferably by the IV route. And then 9, failure to respond to epinephrine in a newborn who has a history or by examination appears to have had blood loss may require volume expansion. And then finally, if all those steps of resuscitation are effectively completed and there's no heart rate response by 20 minutes into that resuscitation effort, then redirection of care should be discussed with the team and the family. And that redirection of care would be away from continued resuscitation efforts and towards comfort care for the baby. So this is the neonatal resuscitation algorithm. I'm not going to take a lot of time to go over it, except that it has not changed from the 2015 consensus guidelines, and it has not changed from the 7th edition of NRP. And I just would point out that the targeted preductal saturation numbers at 1, 2, and through 10 minutes continue to be the same, and I think are very valuable to guide our use of oxygen therapy. So the scope of our problem is this. It's estimated that about 10% of newly born infants need assistance from a resuscitation team to begin breathing at birth. And then approximately 1% will need, beyond that, intensive resuscitative measures to restore cardiorespiratory function. A successful resuscitation of a newly born baby depends on critical actions that occur in rapid succession, done correctly, to maximize the chances of survival. And then of all the interventions we have at hand, positive pressure ventilation remains the main intervention in neonatal resuscitation. And whatever we do as individuals or in teams with our junior doctors or with our nurses, all of us should try to develop our skills and our practice around positive pressure ventilation, but positive pressure ventilation that is delivered effectively, I might add. So let's get into some of the key concepts of the 2020 guidelines as they relate to neonatal resuscitation. As always, supplemental oxygen should be used judiciously, guided by pulse oximetry whenever possible. Prevention of hypothermia continues to be an important focus for neonatal resuscitation. Skin-to-skin care in healthy babies is promoted, it's supported, and we should reinforce it as a means of promoting parental bonding, breastfeeding, and normothermia, whereby the baby derives warmth from the mother's skin and body. Team training, where we practice together, we simulate together. That's an important part of neonatal resuscitation. And even if we talk about and practice anticipating and preparing, doing a briefing before the baby delivers and then a debriefing after the resuscitation, there are important aspects that help us learn from our experiences. Delayed umbilical cord clamping was recommended for both term and preterm babies in 2015. This 2020 guideline affirms the previous recommendation. And then when I mentioned later at the very end of the talk about knowledge gaps, I think one of those knowledge gaps is just what Dr. Narvi talked about is, could there be a better way to manage the umbilical cord? And I'm going to wager there probably will be a better way coming soon. So continue with key concepts. The primary goal of the care of the newborn at birth is to facilitate their transition. If this is an important priority to help them achieve adequate lung inflation and ventilation, and to help them transition from the fluid-filled womb to the air-filled room, or from delivery also to the NICU admission. So therefore, all newborn babies should be attended by at least one person who has the skills and the equipment to give that baby effective positive pressure ventilation. And then concepts in these guidelines, remember we call this newborn resuscitation, the newly born baby. Some of these concepts, such as supporting ventilation, can be applied to newborns during the neonatal period. In other words, from birth to 28 days, not just in the minute that the baby's born or the few hours following that. The 2015 guidelines recommend against routine endotracheal suctioning for both the vigorous baby who has meconium-stained amniotic fluid, but importantly, we continue to recommend against endotracheal suctioning for the non-vigorous infant. So that infant who has no respiratory effort, who looks hypotonic and doesn't look like they're doing very well, we don't recommend endotracheal suctioning. The initial steps and positive pressure ventilation are the priorities in those infants. And then endotracheal suctioning for apparent airway obstruction with meconium-stained amniotic fluid. That recommendation is based on expert opinion. So the umbilical cord management plan, the scientific recommendations, the review suggests this, that it's reasonable to delay cord clamping for longer than 30 seconds in preterm babies, because that reduces the need for blood pressure support, as we've talked about. It improves their preload volume, it decreases transfusions, and may indeed improve survival. And like Dr. Narvi, we're proponents of delayed cord clamping, definitely for a minute if we can get that. And it could occur longer if a normal term baby is actually just put on its mother's abdomen, and we don't intervene at all. And that's obviously a normal, healthy baby. So for the term or late preterm birth, it's reasonable to defer cord clamping until after the baby's placed on the mother and the baby's been assessed by the team for breathing and activity. And this has led to obviously improved hematocrit and iron levels. However, I think Dr. Narvi mentioned it. I had trouble hearing everything, but early cord clamping should be considered when a placental transfusion is not likely to occur. Examples of that would be placental abruption, placenta previa, or a maternal hemorrhage or maternal hemodynamic instability. Cord milking is being studied, and I will now add to that physiologic-based cord clamping are alternatives to delayed cord clamping, but cord milking should be avoided in babies less than 28 weeks gestation because that's been associated with brain injury, as has been mentioned already. Okay, so another big area that we want to be very careful with is preventing hypothermia. We want to maintain the temperature of newly born babies between 36.5 and 37.5 Celsius, and that applies to all age ranges. Hypothermia after birth is common worldwide and a high incidence, obviously, in babies who have low gestational age and low birth weight. Healthy babies can derive their warmth from their mother by accomplishing skin-to-skin mother-baby care after birth. However, for our preterm and low birth weight babies or babies who require resuscitation, warming adjuncts such as radiant warmers, plastic wraps or plastic bags, hats on the baby, warmed blankets, exothermic blankets, and then once they are receiving inspired gases, making sure that those are warmed, humidified gases. These are all things we can do to promote normal temperature. Okay, beyond that, then we're going to move towards supporting the airway, ventilation, and the baby's breathing. One of the things to talk about first is the scientific guidelines suggest that we should avoid unnecessary suctioning. Routine suctioning is not recommended. Suctioning should only be done to relieve an apparent obstruction, because it can induce bradycardia, it can possibly damage soft tissues of the mouth and airway. And so routine suctioning is not recommended. A meta-analysis of 8 randomized controlled trials suggested there was no benefit from routine suctioning, and then 2 more studies supported that. However, if a newborn's not breathing effectively, then rather than worry about suctioning, we should give tactile stimulation, because that may help a baby's breathing improve from the stimulation. But if a baby's crying well, there's no need for us to provide tactile stimulation other than just drying with a towel. Okay, the guidelines on assessing heart rate during resuscitation. As I've mentioned earlier, and as was mentioned yesterday in Dr. George's talk, that the newborn's heart rate is used to help us assess our effectiveness of interventions we're giving, or maybe the baby's spontaneous respiratory effort, and also the response to our interventions. Auscultation of the precordium is the preferred physical examination method. Some people add to that maybe palpating the umbilical cord, but that can be unreliable. So auscultation is preferred. However, we should remember that if they're available, pulse oximetry and ECG, cardiovascular monitoring, can remain important adjuncts to provide us continuous heart rate assessment in babies who need resuscitation. And as I've underlined, especially those babies who need chest compressions, we should place ECG monitoring for continuous heart rate information. And I will say that in recent years in our resuscitation delivery rooms, when we are in fact getting to chest compressions and possibly umbilical venous catheter insertion, it is very nice to look up and to have an ECG monitor giving us feedback about the baby's heart rate, rather than relying on someone to try to auscultate this very faint heart rate. Okay, so the baby's been born, we're supporting the breathing, and we should note that the vast majority of newborns breathe spontaneously within 30 to 60 seconds after birth, if we give them a little help. The adequacy of ventilation is measured by the rising heart rate, as we mentioned, and less reliable would be chest expansion. When we have to give positive pressure ventilation, term babies, it's suggested that peak inflation pressures up to 30 can be used, and in preterm newborns, 20 to 25 centimeters of water pressure with our positive pressure device. Those are usually sufficient, and fortunately, rarely do we have to go higher than that. The lungs of our sick preterm infants tend to be non-compliant. They tend to collapse because of their immaturity, structural immaturity, and surfactant deficiency. PEEP is reasonable to give and to provide at a low pressure inflation of the lungs during expiration to maintain functional residual capacity. A good starting place for PEEP is around 5 to 6 centimeters of water pressure. We can initiate positive pressure ventilation at a rate of 40 to 60 breaths per minute to newborn babies who have ineffective breathing, for whom we are providing assisted ventilation. So if their breathing is ineffective, or they are outright apneic, or persistently bradycardic with a heart rate less than 100, despite what appear to be effective ventilations, or must be ineffective ventilations, then we can proceed with positive pressure ventilation. So I talked a little bit about functional residual capacity. That's what we're trying to sustain and maintain after the baby is breathing spontaneously. So continuous positive airway pressure, one of our forms of respiratory support, helps the newly born baby keep their lungs open. But it obviously needs to be used in babies who are spontaneously breathing. And it's helpful for preterm infants with breathing difficulty after birth or after resuscitation. Studies have shown, a meta-analysis has shown that if we start CPAP, as opposed to intubating and ventilating our very preterm babies, less than 30 weeks, then there's a reduction in the combined outcome of death and BPD if those babies that I just mentioned have respiratory distress. Sustained inflations. There was a very interesting talk yesterday about that concept, and it's of uncertain benefit at this point. It's being studied, and I think we're probably all going to hear more about that in the future. And then our oxygen delivery. You probably recall that if the baby's 35 weeks gestation or more, we want to start with 21% oxygen. We do, however, have the option to use 21 to 30% oxygen if the neonate is less than 35 weeks gestation. Chest compressions. We had a nice presentation yesterday about doing resuscitation to include chest compressions. So we want to be sure that we have given at least 30 seconds of adequate positive pressure ventilation, and the heart rate has remained less than 60 beats per minute, and then we perform chest compressions. The very fact that we're going to initiate chest compressions is based on expert opinion, because there's no clinical or physiological human studies that address this question. And this would be a good time to mention that much of the recommendations in this scientific consensus for neonatal resuscitation and much of the teaching, the content of the neonatal resuscitation program textbook, the 8th edition, are based on a variety of things. Often there's no study to support the suggestion. It's expert opinion, or it's extrapolated from studies that have been done in older children or adults, or it's extrapolated from studies that have been done on animals in the lab. So the thing that is interesting to share with you, and I hope you agree with this, and I hope you have found this in your own practices, it is rare for us to have to actually use chest compressions in full-term babies. It's a little more common in preterm babies, but most term and preterm babies who are not ventilating well at birth and have a low heart rate will respond to ventilation. But in any case, it's rare to have to do chest compressions. So the delivery of those in newborns is done where we give 3 compressions for each inflation. And so we're giving, in a 1-minute time period, 90 chest compressions and 30 inflations for a 3-to-1 ratio, and a total of 120 events in that 1 minute. It is felt that, again, based on expert opinion, that the 2-thumb encircling hands technique has benefit over the 2-finger technique. Vascular access. Babies who have failed to respond to positive pressure and chest compressions for at least 1 minute together and continue to be bradycardic, they will require vascular access for us to infuse the primary medication, epinephrine or adrenaline, and also volume expanders. In the delivery room setting, the primary way that we achieve vascular access is with umbilical venous catheterization. If UVC, for umbilical vein catheterization or any kind of venous vascular access is not feasible, then the intraosseous route may be a reasonable alternative. But that's determined by the availability of the right equipment, training on the providers, the practitioners, and their experience in doing it. And no human studies have been done to show that UVC is superior over intraosseous. Again, it's based on expert opinion. Those medications, I know that Dr. George talked a little bit yesterday about epinephrine or adrenaline. Again, the reassuring thing is we rarely need to use that. Most babies are going to respond to the initial steps and ventilation. So the indication to give epinephrine is if our heart rate remains less than 60 beats per minute after ventilating and giving chest compressions, ventilating with 100% oxygen, giving chest compressions, then we can give epinephrine. The best route is the umbilical vein. The dose I show you here, 0.01 to 0.03 milligrams per kilogram. However, if we have to give only endotracheal dosing, it's a higher dose, usually triple that volume. And it's a reasonable alternative, but as soon as we get vascular access, we should give a intravenous dose of epinephrine. And we can repeat the dose every 3 to 5 minutes if the heart rate remains unresponsive or less than 60 per minute. And then again, no adequate study has been shown that UVC or endotracheal dose is superior. I do think that our empiric experience is that as soon as we give intravascular doses, babies respond to that. The idea of volume expansion. If we suspect, based on a baby who has blood loss or a pale appearance or weak pulses or persistent bradycardia, and the clinical scenario suggests it, then we can consider giving volume expansion, especially if that newborn infant has responded poorly to ventilations, chest compressions, and epinephrine. The dose is 10 mLs per kilo over about 5 to 10 minutes. I would suggest that it's often given quicker than that, closer to 5 minutes, and that's a reasonable choice if there's not an adequate response above, and it can be repeated. And then normal saline, 0.9% sodium chloride is our crystalloid fluid of choice. And that initial volume of 10 mLs per kilo can be given and repeated if the baby is still not responding and we feel like they have shock. No evidence from randomized trials to support the use of volume resuscitation. A large retrospective review found that giving volume is a very rare event, usually in the face of confirmed blood loss like a placental abruption. And there's insufficient evidence to determine what type of volume expander we should use, crystalloid or blood, but crystalloid is so much more readily available during resuscitation. Post-resuscitation care. Babies who have received prolonged PPV or advanced resuscitation, they should be monitored in a NICU. Infants greater than 36 weeks who received advanced resuscitation should be evaluated for hypoxic ischemic encephalopathy to determine if they meet criteria for therapeutic hypothermia. Hypoglycemia is common after resuscitation, and those babies should be monitored and treated appropriately. And then occasionally we do have unintentional hypothermia, and if it's not contraindicated, we should immediately rewarm them once we can stabilize them. And so we all know that cooling works. Babies, late-term and preterm infants who with moderate to severe encephalopathy and evidence of interpartum asphyxia, therapeutic hypothermia did reduce the combined outcome of mortality and major neurodevelopmental disability. Babies who have abnormally low glucose levels, both low and high, are at increased risk for brain injury because of that. Care that, a word about the concept of not beginning care or stopping care. If the heart rate remains undetectable and all steps of resuscitation have been completed, it is reasonable to redirect the goals of care. In other words, to talk to the family about stopping resuscitation. Neonatal and bioethical committees agree that in certain conditions, it is reasonable not even to initiate therapy or to discontinue life-sustaining efforts. That decision should be individualized, and whether we continue or discontinue, it can be considered after 20 minutes following birth if the baby is not responding to resuscitation. Other difficult situations like extreme immaturity or babies known to have fatal conditions, expert consultation and parental decision-making should be involved. I think we can end there. Just the final thing I'll say is there are many knowledge gaps that still persist as to what are the best things we can do in newborn resuscitation. And I thank you for your attention and thank you for the invitation, and very nice to be with you again.